Hi everyone, and welcome to the Otolaryngologic Clinics Podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the October 2023 issue dedicated to external ear disease, guest edited by Drs. Esther Vivas and Matthew Hanson. Here now is our consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. Today I'm speaking with the guest editors of the October 2023 issue of Clinics on external ear disease, Dr. Matthew Hanson and Dr. Esther Vivas. Dr. Matthew B. Hanson, MD, is Director of Otology and Neurotology in the Department of Otolaryngology at State University of New York at Downstate. He's assistant professor at SUNY Downstate College of Medicine. He's the chief of otology at the University Hospital of Brooklyn and at the Kings County Hospital Center. And he's the director of service of otolaryngology at Kings County, which is in Brooklyn, New York. Dr. Esther X. Vivas, MD, is division chief of otology and neurotology, director of the Surgical Dissection Laboratory and Temporal Bone Course, and professor in the Department of Otolaryngology Head and Neck Surgery in the Division of Otology and Neurotology at Emory University in Atlanta, Georgia. Welcome, Matt and Esther.
Thank you.
Thank you.
So, listeners, you can get this issue and all issues of Otolaryngologic Clinics of North America at your personal or institutional library and online at www.oto.theclinics.com. You can access one podcast per issue since 2017 at that website or wherever you get your podcasts. Matt and Esther, you start this terrific issue with a great foreword about the joy of being a, quote, external otologist, end quote, which I love that phrase, and with a terrific historical foreword by the grand poobah of the ear canal, Dr. Frank Lucenti. You rightly point out that although earwax and swimmer's ear may not be as titillating as, say, cholesteatoma or otosclerosis or vestibular schwannoma, ear canal issues affect many more people than all of those other disorders combined. And it really is a joyous feeling to help somebody with an ear canal issue that's causing them to have pain or fullness or hearing loss and restoring their quality of life right there in your office. I remember being young in otolaryngology and otology and seeing that Dr. Lucente, who really was such a highfalutin guy even back then, see him focusing on ear canal disorders. And I think that really drove home the point to me that there is a great deal of importance to what is considered run-of-the-mill care of the patient, as well as taking care of the esoterica. So I want to congratulate you on a great issue of Clinics, and I want to spend the next little while talking to the two of you about some of the key points here. So I'm going to start by asking Dr. Hanson or Matt a question. So readers, I will tell you that I really like these two and we are really good friends. So if I switch between Dr. Hanson and Dr. Vivas to Matt and Esther, I'm going to call that my prerogative. So so Matt, you wrote the first article and you co-wrote the second article along with Dr. Matthew Adams on examination and evaluation of the ear canal and cerumen and the biome of the ear canal. So can you tell us what are the most important parts when a healthcare provider is evaluating the ear canal? And then can you tell us what exactly is earwax and why does the biome of the ear canal matter?
My experience in external otology actually began with one of my early mentors, Simon Prizier, and we did a couple of articles together and textbook chapters on the external ear when I was with him. And then when I joined Frank, he took me under his wing. I was very much inherited his practice, and so I still see a number of his patients on a regular basis. And it's fueled my interest into it. One of the things that Frank always emphasized, above all, was the ability to examine and clean an ear in a pain-free fashion. And he was very insistent that residents learn how to work with a microscope, work under a microscope to clean an ear in the office without causing the patient distress. And that means getting all the wax out, getting all the debris, and being able to see all of the skin of the ear canal. And I think that when it comes to evaluating the external ear, you have to really do that. You have to be good about getting rid of pus, debris, junk. I think that's especially true with a lot of the fungal infections, because you have to be able to push away and clean away the biome, or the biofilm in which they live, or you're never going to get rid of them. And so cleaning the ear, I think, is the number one thing. I also emphasize to my residents, at least, that learning to clean an ear under the microscope in the clinic is one of the best ways to prepare yourself for otologic surgery, and learn how to use a microscope as an extension of your eyes, and use two hands while you're operating. And so I don't want them to ever bypass the opportunity that presents. The ear canal is a very fascinating place. It has different areas of it that have very different physiology. The bony canal is different from the cartilaginous canal, which is different from the meatus, which is different from the auricle. And they all have special adaptations that they've had. When we look at the articles that have been written on cultures of what the biome of the external ear is, they have changed dramatically over the last 40 years based on our abilities that we have to identify organisms. And it used to be they would basically take a swab of the external canal, put it on a plate and grow it, and then say, these are the organisms we got. But if you didn't plate it in the right way, if you didn't, and then we found that, we found fungus in Canada when we looked in the sebaceous units, but we didn't find them in the earwax, or we didn't find them on the skin. It became obvious that they were supposed to be in different areas. The identification of organisms now is a very complex thing, because identity of a bacterium is based on their ribosomal large subunit and PCR, and same is true for yeast, where we're using the large ribosomal subunit. So it becomes a matter of being able to get a specimen and get it to a PCR lab, and being able to identify what actual organism is, and that kind of slows everything down and makes it a little more cumbersome. But when we do that, we find that there are certain organisms that are always there. I had never heard of Malassezia when I was a resident, or earlier in my training, but it's an incredibly important little organism that lives in our sebaceous glands and can only survive on sebaceous secretions. And when we have that person that comes in with earwax in one ear, that we're having to clean out their right ear every 3 months, but their left ear never has anything in it, that's probably the reason. They probably have a difference in the biome on the two sides. So the biome of the ear canal really definitely matters. It especially matters when we start treating patients with antibiotics, and we change that biome, and that kind of puts things in a different realm once that heals, and we start seeing organisms we haven't seen before. And so it's something that I've seen quite a lot of lately.
So I think those are terrific points, because I think we all take care of people who have been treated for otitis externa elsewhere by a non-otolaryngologist, and they're given drops that they happily are putting on top of debris and discharge and drainage in their ear canal that's clearly not reaching anywhere. And I must say that although a microscope is still the gold standard, a good operating head otoscope, if that's all you have, is terrific. And in the developing world, there are actually almost barefoot doctors who go around who essentially make a wick out of a long piece of cotton and just use that to clean the ear canal so that air can get to the skin and whatever drops are available can get to the skin. So I think this concept of cleaning the ear correctly so that you can see as much of the anatomy normal or inflamed or whatever is really very important. Esther, Dr. Vivas, despite Dr. Lucente's concerns about people manipulating their own ear canals, and I really recommend everybody read Dr. Frank Lucente's foreword because it really reflects a lifetime of reflection on the ear canal. But you both chose to include this article on, quote, do-it-yourself ear canal care by Drs. Tam and Hunter. And I'm going to tell our readers that there's a really good accompanying video that you can check out at the website at oto.theclinics.com. So what is safe and what is not safe for people to do to their ear canals?
There is so much out there. And I think that what this article, it highlights a few of the things out there, but the reality is that there is many more. And we, as providers, really have to try and keep up to date on the things that are being advertised to patients, whether it's down the aisles in a CVS or online on Amazon, because there's just an insane amount of product being sold for this purpose. And so we gave a little glimpse in the article, but the bottom line is that even in the most well-intentioned designs, most of the products out there can cause harm. And so what we need to be mindful when we are counseling patients is that there are many instruments that can be safely used when someone else is doing it for you and have direct visualization. But when you're doing things yourself and you're kind of digging in the ear and trying to flush and or put something down there with a video on your phone, there's higher risk for something going awry and ending up with a bleeding ear, or worse, a perforated drum, hearing loss. I mean, we've seen sublux stapes from Q-tips being dislodged and all kinds of horror stories. But there are a few things out there that in the setting of a normal eardrum, some flushes can probably be, if people are trying to spare how many visits they go to to see a provider for, if it's recurrent wax. I mean, there is a role for some of these that have some gentle irrigations, as long as precautions are taken as to what you're putting in your ear, some peroxide or the old school alcohol vinegar rinses that we all grew up using, and I still personally recommend. So I think that those are some of the safer things that we can tell patients to use.
And I agree with you, and thank you. I will caution our listeners that if you're asking people to do rinses, please make sure that they're using body temperature liquids and not giving themselves a cold caloric. And getting a vertiginous episode in a bathroom somewhere. I think that's really important. I think it's really important even when they're using drops. We used to tell people, and we still tell people, kind of warm it up by placing the bottle under your armpit for a couple of minutes, and that'll get you to body temperature so you're not dizzy when you put in these drops. You should not be using most of these irrigants if there's a concern about a perforation of the eardrum. Obviously, this article has a lot of really good pictures, because sometimes I don't even know what the patients are talking about when they say, "Oh, I got this blah blah blah," online, and I'm like, I don't know what that is. One looks like a corkscrew. Matt is currently sticking something in his ear and showing us a very beautiful looking right eardrum
nice?
on his smartphone. So again,
$30 on Amazon.
But I'll tell you something, you're smart enough to keep your other fingers at a place where you can't jam that camera in deeper than about what, a millimeter? I'm sorry, about
I actually took the earwax spoon off of it. I just
so
use that endoscope now. So it screws off and you can do that. And it's 30
and you just want to be careful about that.
Yeah.
I do want to mention ear candling.
Yeah.
So I know that in this article, Tam and Hunter talk about ear candling, and I understand that as physicians, we only see the bad outcomes. But what do you say to somebody who asks you about ear candling, Esther?
Be careful. If you're going to do it, you're going to do it. But we often see, and sometimes they're not there for particularly problem related to the ear candling, but it gives that speckled appearance to the eardrum. It looks like, I don't know what to call it. It almost looked like the eardrum had chicken pox, and it's got all these little dots around it. And I usually ask, have you been ear candling? And the answer is yes. So, it's people do it. Lots of people do it safely. Sometimes, you can cause a mild discomfort or even a mild burn. But I don't ever really encourage it. I'm never in a position where I say, okay, go ahead and do it, because I just don't feel right giving the green light, but people do it anyway.
How about you, Matt?
I feel about it kind of the way I do about, acupuncture and things like that. Like I'm not really certain about the scientific basis of how it works or what it works, and I don't think that their explanations actually hold any credence. But there are people that believe in it, and there's a definite placebo effect and power of belief that goes with it. And just like Eustachian do balloonplasties, there's a lot of problems that present with sensation of fullness in the ear that will respond to placebo type of interventions. So I strongly discourage it based on the history of reports of severe burns and things like that. But I know that that's a rare thing. And I still have patients that come in and have it done. So it's
So I think we, as physicians, we do our best to try not to advocate for things that either don't work or could harm. And having taken care of somebody whose entire tympanic membrane was burned away after candling, and it's an N of 1. But why? And I think a lot of the debris that they show people after they've done the candling is the candle wax that's burnt itself, right? Because I agree with you. I see stippling and so on. So I think just because a doctor's not doing it doesn't make it safe. And I think that's the same for certain types of herbal remedies, etc. But let's proceed and talk about foreign bodies in the ear canal. So I'm going to direct this question to Esther, to Dr. Vivas again. Okay. So someone's grandmother somewhere said, don't put something smaller than your elbow in your ear. But unfortunately, nobody's listening to that grandmother. So, we have a great deal of experience taking out all sorts of foreign bodies from the ear canal: beads, hearing aid domes, bugs, pieces of tissue paper, all sorts of things go in there. So there's an article on foreign bodies by Drs. Curry and Maxwell. And what do you think our listeners should remember the most from this article, Esther?
Some of the driving points relate to maybe organic products that can get, things that could be animals, insects, and how to manage those. They can be quite painful. I've taken out all kinds of insects and ticks from the ear. And one of the things logistics to figure out is, how do you control or take care of the animal in a controlled manner so that you limit more damage to the surrounding structures. And the authors make a good point of how to do that. You can try to kill the animal, douse it in some oil or lidocaine in some situations, as long as there's no perforation in the eardrum. and then use forceps with some other instruments. But the other takeaway point is batteries, especially in children or patients with special needs that may put objects in their ears, is that those are really urgent situations that you want to keep the ear as dry as possible. Don't put anything, liquids or drops or what may be in the ear when you're trying to dislodge those. You can actually cause more harm. And so I think those two are, there's a table 1 that kind of goes through an algorithm and the different instruments and how to use those. But some of the takeaway points are those that is for the ones that are related to like a safe retrieval of the objects. And then the other aspect is the logistics of the types of instruments available out there to do that with. So it's a great little review of what's out there.
Yeah, and I would say that we've seen some issues with people using the wrong instruments or inadequate visualization and ending up with that object going from the external ear through a perforation that's now been created into the middle ear. So if you can't see or you can't manage it, it is best to stop and call the otolaryngologist and say, can you please do this in a manner where you have the right equipment? Recently, the New England Journal of Medicine tweeted a video of a spider crawling around the medial ear canal, having sloughed off its molten skin right next to the TM. And it was pretty cool. And I have to say, coming out right before Halloween was really quite interesting. If you wanted to itch, it was a good video to watch. So, Matt, let's talk about acute otitis externa. So it can be really, really painful. And we're sometimes seeing some very odd management of this condition. So the article by Doctors Woodhouse, Plum, and Wong talks about acute otitis externa. So let me put a couple of questions at you. What causes AOE? What's the most efficient way to treat it? And then when does it go from this sort of uncomplicated, ear canal infection that's kind of managed to something that is more complicated or needs a higher level of care, or maybe even needs a culture, as we talked about earlier in this podcast?
Okay. Yeah. This chapter was written by a partner of mine in pediatric otolaryngology, Ann Plum, one of my residents, and is based largely on the clinical practice guidelines recommended by the Academy. And, I think that the evidence-based clinical practice guidelines are a very good place to start for a lot of different things. But it's important to remember that they're guidelines and not rules, and it's not a Bible. The important thing, I think, in all of these patients is to recognize it. A patient comes in with pain. It may be TMJ. It may be something else. We still see patients with that disorder that's the longest name we deal with, chondrodermatitis nodulus helicus chronicus, where they have a specific part of their cartilage that is very, very tender and painful. And, that's not something that, Ciprodex is going to help. And it's if they are able to do a good exam of the ear, see the redness, history of water exposure, a history of instrumentation, much more common in lake swimming and occasionally in pool swimming than it is in ocean swimming, but a very common summer complaint. All it needs to be treated with is analgesia and drops, and that's it. And there's so much evidence in its favor that has been made one of the quality measures that CMS follows for quality measurements of doctors for merit-based pay. The result of that is that everybody's treating all of these things with drops. When people come in with ear pain, they're getting prescriptions for ofloxacin and Ciprodex and other things. I've seen people treated with earwax that had these. I've seen people treated with Otalaryngologic from TMJ. that they're treated with these things, and these medications are not 100% benign, especially considering the multitude of organisms that are supposed to be living in our ear, and it allows certain other things to grow. So I think following those guidelines and doing a good examination of the ear and being able to know when the person has this is probably the most important thing before putting them on drops. There are certain situations, though, where I think that you do need to think about doing systemic antibiotics. And I think one of them is the person that you cannot see in the ear. There's so much swelling that you can't see in the ear. If you're going to have to put a wick in the ear in order to make certain the drops get down there, I'm not certain enough of my penetration to not want to put an oral antibiotic in there as well. If the person is a diabetic, I'm much more likely to want to put them on an oral antibiotic in addition, because I'm afraid of it advancing to necrotizing otitis externa. If I don't know the status of the eardrum, that makes me also nervous. But generally, we can figure that out, and we'll treat you'll put a wick in, and we'll give them antibiotics and drops first, and then see what happens. But they have to have some, even if they go to an urgent care center and any type of storefront doctor, and they do that, most of those places, at least here in Brooklyn, are very good about sending those patients to me or to an ear, nose, and throat within a short period of time. And I think that's probably the most important aspect of it, is that the person is given some follow-up with somebody that can actually look at the ear, clean the ear, and know what's going on.
And, we talked about the fact that this article is written in the northeastern portion of the United States. In Atlanta, also known as Hotlanta, the environment is a little different. It's a little bit more humid year-round. It's warmer. Do you see anything different, Esther, that you pay attention to with these acute otitis externas down there?
We certainly have a lot more fungal components of the otitis externa, and they can be pretty aggressive. And particularly, speaking to Matt's point, like when they're diabetic, it's a slippery slope in how quickly people can deteriorate. And sometimes not so quickly. They'll present with months worth of problems that ultimately end up in the hospital. But the fungus in the ear is quite problematic down here. And you have to be very aggressive because it's not just the fungus, but it usually has a Pseudomonas super infection. And then those folks can get pretty sick.
And I think it's really important to highlight the necessity of proper water precautions in these individuals. So everyone who tells me, oh, yes, I put cotton in my ear when I take a shower, I'm like, that's wicking the water in. So you really want them to be using either cotton covered with like petrolatum jelly, Vaseline, or you want them to use a silicone earplug. You need them to actually keep the water out of the ears in the time that they are suffering from the AOE and resolving it. So Esther, let's stick with you. There's an article by Drs. Munjal, Kolar, and Aliano on the difference between keratosis obturans and external auditory canal cholesteatoma. So how are these entities diagnosed and managed differently from each other?
Well, the keratosis patients are really so difficult to treat in a lifetime, because if you think about how much debris accumulation they get over a lifetime and how many visits they require to have their ears debrided, it's quite an impact in the quality of life, kind of like what you said at the beginning. And those patients just need routine debridement, whether it is through a physician's office visit, or some patients can irrigate themselves and try to manage it that way. And so your question was keratosis obturans versus the canal cholesteatoma. Is that okay? Yeah. And so that's the keratosis accumulation is a rather benign process in that you get much of the canal bony erosion and the superinfection. It's more of an impaction that tends to be often dry, but just accumulates and it needs to be removed. And so you don't need any special topical treatments typically, but just to have it debrided with instruments. However, canal cholesteatomas can be progressive over time and they can cause bone erosion, and they need to be managed a little bit more aggressively and may need definitive management surgical wise instead of just routine office visits.
I think that the difference between the two is really quite amazing. There, when I was doing an article on this myself, I was very fascinated about being asked by the resident that was helping me. So why is it associated with bronchiectasis, keratosis operans? And I had no idea it was, and I have never seen that. I have never had a patient that had bronchiectasis and keratosis operans. The patients I see that have keratosis operans are the ones that have wax that continues to build up, and they do this. They push it in more, they push it in more. And even though they're not hearing well, they keep pushing it in, they don't let it come out. And when we open it up, there's just this complete 360-degree enlargement of their ear canal to the point where, their eardrum is like a little circle on the wall. And it's a symmetric enlargement. Many of those patients I've actually ended up doing canalplasties and meatoplasties just to make them easier to clean, because sometimes it's not easy to get around those things. I've had several of those patients where the keratosis has eroded into the mastoid air cell systems, and now they have a formal cholesteatoma in the mastoid that they often end up with a canal wall down as a result of that. And they have no problems with middle ear aeration. They have no problems with cholesteatoma of their eardrum. In fact, their eardrum is completely normal, and oftentimes they have relatively normal hearing. So it's a very frustrating thing to see. Canal cholesteatoma tends to be more isolated, and it's almost always associated with some areas of necrotic bone. It has to do with how the ear canal skin migrates and how it deals with attempting to migrate over dead bone, which it can't do. So it builds up underneath it. It builds up underneath that dead bone, and over time it'll extrude that dead bone. I've removed these from hundreds of people, and most of them are fairly small, but I've had some that are just absolutely enormous. And this is a good picture of one. That's the person's eardrum up there, and that big divot on the bottom is all the patient's ear canal, which our people on the podcast will not be able to see that picture. I'm sorry, but it can be a very, very destructive lesion. Both of them have some degree of bone erosion, but it's not a focal bone erosion with the keratosis operans. One of the things that can fool you about keratosis operans, by the way, especially when I look at the picture on figure 1 from the article, I'm not certain that's a keratosis operans as much as I am that that's probably a Candida parasilosis infection. There's various forms of Candida, and one of the ones that we see a lot of is parasilosis. And unlike albicans, Candida parasilosis makes a very, very dense proteoglycan biofilm that it lives in. And this is like a big cast. It makes a cast of your ear canal. And you get the skin underneath it has the infection, and it gets kind of white, and they build up more keratin, but this cast kind of keeps it from moving. And so a patient with something like that, and I think this is true of a lot of keratosis operans, is there sometimes is something going on from an infectious standpoint that is causing increasing production of keratin and biofilm formation within those layers that is causing the actual bone erosion.
That's really interesting. It's like an ogre, right? It's onion layers, and you just peel back a layer and you see more and more if you only look. So we have touched upon fungal otitis externa with both Drs. Hanson and Dr. Vivas. So I'll just direct our readers to the article that you wrote, Matt, with Dr. McCarty-Walsh, because you've got some really good pointers there.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Sujana Chandrasekhar. I'm the Consulting Editor for Otolaryngologic Clinics of North America. I'm speaking with Drs. Matthew Hanson and Esther Vivas. Dr. Matthew Hanson is of Downstate Medical Center in Brooklyn, New York. Dr. Esther Vivas is of Emory Medical Center in Atlanta, Georgia. They are the two guest editors of the October 2023 issue of Otolaryngologic Clinics of North America, which is on external ear disease. You can get this issue and all issues of clinics, hopefully at your personal and definitely at your institutional library and online at www.oto.theclinics.com. We have recorded one podcast per issue since 2017, and you can get them at the same website or wherever you get your podcasts. So let's move on to ear canal stenosis. So as you started out by saying at the very beginning, Matt, the ear canal has so many parts to it, and ear canal stenosis is sort of globally divided as at the bony canal or in the cartilaginous portion of the canal. It can be a bony stenosis or a soft tissue stenosis, and it can be acquired or congenital. And we know that any surgical manipulation to try to reverse ear canal stenosis or narrowing often results in scarring with further narrowing. So since we do not like pushing a rock up the same hill over and over and over, I think before we try to intervene on these patients, we need to do a little bit of thinking. So there's an article on acquired stenosis written by Drs. Munkekar and Entezami. And then there's an article on congenital oral atresia written by Drs. Morrison and Kesser. So, Esther, what causes acquired stenosis of the ear canal, and what are the sort of very nutshell options for management?
Lots of things can cause the stenosis. Chronic inflammatory conditions, trauma, infection, tumors. I mean, it's actually quite an extensive list of things that you have to keep in mind as to what's caused stenosis. And quite frankly, it is one of the more frustrating things to treat in the clinic, because when you take these patients to surgery, it's the rate for restenosis tends to be high. And I've had people who have done well for years, and as pointed out in the article, these things, these patients can restenose many, many years out, even after a successful surgery. And so you really have to have kind of a long list of what is going on in the ear, what kind of, it's all related to inflammation or trauma, right? So if it's inflammation, is it an infection? Is it a bacterial inflammatory process? Is it a fungal inflammatory process? Is it manipulation of the ear from maybe there's chronic itching from underlying allergies? And so it's quite a bit of history that you have to try and take from these patients, because that drives your management. If you can identify what is the underlying inflammatory process, then you can obviously tailor your treatment that way. Some of them are completely idiopathic. You just don't get any history from them, but you often can get a sense of what's going on. And post-traumatic stenosis is probably the easier one to manage, because if you reduce the fractures and you take them to the OR and just kind of clean it up, those patients tend to do better than the ones from an inflammatory standpoint.
And I will point out to our listeners that there's some really nice tables and figures in the article by Munkaker and Entezami. There's the acquired stenosis of the external ear canal classification by Taus et al. And Levy et al. And then table 2 has a modified subclass of this stenosis based on the classification. And just like you said, Esther, it's idiopathic, post-inflammatory, post-accidental trauma, post-iatrogenic trauma, neoplastic, or dermatologic. And I think when you have a list that's that long and that varied, you can see why it becomes such a challenge. There's also a very nice interpretation of the pathogenesis of the inflammatory cascade that may end up leading to a pretty significant stenosis of the ear canal. In the article on congenital oral atresia, I will remind people that we still use the grading system. So we either use Antonio de la Cruz's grading system or Robert Jarsdorfer's grading system. And Morrison and Kessler have given us a table to help us interpret what number they get to on those grading systems in terms of how we can counsel the patients and their families on prognosis. But Matt, do we just chase our tail and keep trying to open up an ear canal, or do we realize that time has passed and that our osseointegrated implants are really outstanding nowadays? And when do we just say to people, the goal of your ears is for you to hear, and let's talk about hearing? So when do you get to that point where you stop chasing the ear canal and just focus on the hearing?
When I talk with other otologists around the country and I go to national meetings, I'm actually stunned at how many fellowship-trained otologists, neurotologists will no longer touch an atresia. They will just put a Baha in it. They'll say, why do that? You're just going to make a problem cavity. You're not going to have a great hearing, and you're going to get great results with the Baha or with any type of bone conducting osseo or whatever. And they're absolutely right, but there are patients that, when Jarsdorfer started using his scale, he would say that he wouldn't do anything lower than a 6 or a 5. And I look at it and go, boy, once I get to 8, I don't want to do it. And
I agree 100%.
And
if it's below an 8, no.
So there, and having inherited a lot of the Jarsdorfer patients, especially in our community here in New York, that come to me for routine cleaning on a regular basis, the advantage that they have with their atresia repair is not really that high. They still have a conductive hearing loss. They still probably could use a hearing aid, but the big motivation for that is to not have a hearing aid. That's their big reason for going with the atresia repair, because they don't want the child to have a stigma of having to wear a hearing aid. And it's a hard cultural thing to stop, because it is cultural, it is historic, and that is the thing that pushes it. But I'm very careful about what atresias I fix anymore, and I'm happy to say I get pretty good results on those. And if they can get through high school with no ear infections and no need for hearing aids, I'm very, very happy.
Well, thank you. Yeah, I think that's it reflects how you have to look at the person as in the entirety, and how much time they want to spend in your waiting room and your office, with repeated postoperative care, when maybe all they really do want to do is hear, and we can fix that pretty readily. Dr. Lucente, in his foreword, made particular reference to the importance to understand the overlap between otolaryngology and dermatology in the care of the external ear. And so for many of us, whether we're otologists or comprehensive otolaryngologists, we're talking about things that are frustrating, right? Chronic dermatitis of the ear canal can be pretty frustrating for us, and certainly even more so for the patients who are laboring under this condition. So I have to say, having read this issue a few times, as you know, I read it, in the process of it being created, and then I read it later, and then I read it again to prepare for the podcast. I found that the article on dermatologic conditions of the external ear, which was actually written from the dermatology point of view by Drs. Leibovitz, Koblinski, Hogue, Cheeley, and Blaylock, I found that this article is worth the price of admission for the entire issue. I think that there's some amazing pictures in here. I was very impressed that the authors chose different skin types, Caucasian and non-Caucasian, to show lesions, which look very different on different colors of skin. I like their tables very much. There's a table 1 that talks about all the topical steroids you can use. There's a table 2 that talks about steroid-sparing agents. So I'm going to ask you for 3 pearls, Matt, from this article.
I think that one of the most important things is that this highlights the different areas that we deal with in the external ear. When Esther and I were asked to do this, we decided to leave the auricle out, because there are a lot of things on the auricle, like microtias and that we really didn't want to get into and want to just talk about the ear canal. But when we talk about the external ear, there are things that you see on the auricle that you're not going to see that much in the external auditory canal. The meatus of the external auditory canal, the lateral meatus of the external auditory canal, is a place where there are a number of allergens that collect there. We always leave a little bit of our soap there after we bathe. We always are, all the things that are floating around in the atmosphere tend to collect there during the day. So people that have a tendency for atopic dermatitis all get that. They get some eczematous and seborrheic changes in that area. They're very popular places for these things. And some, we see patients all the time with hearing aids that get a dermatitis in relation to their ear mold material. And it becomes a very difficult thing to treat. I think one of the other important things about it is not only knowing about all these different things, but knowing how to differentiate them and how to diagnose them. Because a lot of them you don't need to have a biopsy for eczema or seborrhea or all these other things, but some of these you do. And I've actually diagnosed T-cell cutaneous lymphomas in the ear canal on 3 occasions in my career. And that, these were external ear infections that just didn't get better. And same is true with the patients that we think of for necrotizing otitis externa. I've had 2 of those turn out to be cancers. And so the importance of biopsy, can't be understated. This is also another thing where emerging knowledge of our pathogens and our our ear canal biome makes it important. I talked about Malassezia and this form of yeast that is an obligate, has to have an obligate fat source, so it only lives in our sebaceous glands. But it's the yeast that causes tinea versicolor, and so it's known for causing a pigmented lesion on the skin. And it all has to do with how many of these organisms you have. And if they're eating all your sebum, they're going to create a dry skin. And it's one of the major sources of eczema and seborrhea. So in many of these cases, there may be an infectious component to it as well. So it's I think very important to have somebody that you can work with that is a dermatopathologist. The person that I had initially asked to author this article, who was not in the country at the time, was our chairman of dermatology here at Downstate, Edward Heilman, who's a fantastic dermatopathologist, and he's somebody that really is a storehouse of knowledge for me. But when I have a patient like this, I always like to have him look at the slides, so and tell me what else I need to do.
I think as a pointer in terms of clinical practice, sharing this particular article with your dermatology colleagues is really, really helpful. I think reading it through a couple of times and, putting those pictures into your memory bank, but certainly sharing it, because we do share care of these patients and we would like that care to be targeted appropriately. So, Esther, Matt mentioned biopsies and having an index of suspicion for cancer, and the article on external ear canal neoplasms, which is written by Dr. Mallory Raymond, these neoplasms are often diagnosed in a delayed fashion, and interestingly, sometimes they present as the tip of the iceberg. There's a small little thing there, and then bam, you need to do way more than you expect. So talk to us a little bit about how we maintain an appropriate index of suspicion.
That's a great question. One of the reasons the neoplasms tend to be diagnosed in a delayed fashion is because they're often treated as an ear infection. And so they'll see, some redness. Patients often have pain, discomfort, and they'll get treated with drops, often get treated with multiple courses of topical medication. And it's not until they've gone through several courses that they get a referral to an otolaryngologist often, or, after a few urgent care visits. And anything that looks fleshy in the ear canal, you really should be thinking about biopsying it earlier than later. And I think that's the takeaway, is that high index of suspicion goes a long way. And if someone comes to you and they've already been on several courses of drops and it's not getting better, then you got to think what else is going on.
We used to hear that if you felt that the granulation tissue was sort of at that juncture between the bony and cartilaginous canal, that should increase your index of suspicion. Is there some backing to that?
Absolutely. I mean, I think that junction is a conduit to your other parts that can have a source for metastasis, right? Those natural channels that can let disease travel either towards your parotid, down into the neck. I mean, there are different well-established anatomic channels that can do that. And so that junction there is clinically very relevant. And so absolutely there's validity to having that kind of pearl in the back of your head. If it's granulation tissue there, you got to be thinking something more ominous.
So, radiation therapy is used, as we know, to treat various things. In the very old days, apparently radiation therapy was used to treat adenoiditis and tonsillitis and acne. We have proceeded from there to actually limit it to be used for tumors. But we have people who get radiation to their head and face and neck, and sometimes the ear canal is unable to be blocked out adequately. So there are changes that we all see when people have had radiation that has affected the ear canal to some degree. Mm-hmm. So, Esther, I noticed that you asked your colleagues at Emory, Drs. Brooks and Gross, to author the article on radiotherapy-induced pathology of the ear. So obviously, ideally, we block the ear and we don't get it involved in the radiation. Other than that, what are the best ways to minimize damage and ameliorate any long-term effects from radiation to the ear canal?
That's a great question. We have a lot of these patients. We have a very robust oncology practice, and as such, lots of these patients have to come see us for care after treatment. And radiation is very interesting because you really go through a transition of an inflammatory process, and seeing them during active treatment to years out, the ear goes through an incredible transformation in terms of the quality of the skin. Initially very soupy, starts to weep a lot, and ultimately it dries out. And then you get to a position where you can have exposed bone because the skin has atrophied. And something that I learned early on is that these patients in the earlier phases, they need, they're going through a lot of through treatment anyway, but they really do need to come and keep their ears dry. Frequent debridement and keeping that ear dry of debris, not with drops, not with anything like that, but just kind of natural debridement with just instruments, and shielding it from water exposure goes a long way. But it's a problem that you're trying to keep them alive, but increase their quality of life when it comes to their ears. And so it's a tricky balance you have to keep with them. One of the important things to take away is you got to know when you're capturing them after radiation. If it's early on, it's going to be a very inflamed, soupy ear. You got to keep them dry, more comfortable. I always tell people, don't put tubes in a radiated ear with an effusion. You're just going to create a whole lot more problems than, a fullness sensation and hearing loss. It's just a terrible situation. I strongly advocate against it, and I think we all should. And these patients, the only thing that we've ever put tubes in is severe barotrauma when they need HBO for their treatment for wound dehiscence. But otherwise, it's really important to keep that ear dry. And if you put a tube, then that becomes a wet, even more wet ear that is just very problematic.
I'll point out that in this article by Brooks and Gross, there are two really good tables. The National Cancer Institute terminology for radiation-induced dermatitis, because I think until we all speak the same language, it's very difficult for us to understand what our colleagues are saying or what our patients are actually going through. And then in table 2, they have the grade and recommended treatment, and they compare 1999 to 2017. And I think this is really interesting to see how we have incorporated that which we have learned into the recommendations. So as we come up towards the end of this podcast, and I really want to thank both of you very much, I want to talk a bit about what used to be called malignant or necrotizing otitis externa, and which is really called much more accurately skull base osteomyelitis. So this, whatever we call it, potato, this remains a life-threatening illness, and it causes pain and often cranial neuropathy in patients who are often elderly and or immune compromised. So there's an article by Hamiter, Amorosa, Belden, Gidley, Mohan, Perry, and Kim, and that incorporates knowledge again from various specialties called upon to care for these patients, which includes otolaryngology, infectious disease, and radiology. So Matt, what do we do? We've talked about, high index of suspicion. We've talked about early biopsy, looking for granulation tissue. How do we get to them and get them treated before this rapid spread happens along the skull base and there's cranial nerve involvement?
I would love to say that early examination, high suspicion is it, but oftentimes these patients are seen over and over by doctors that don't know what they're looking at, or treating them with drops, treating them with anything that they can, where they don't entertain this idea. And oftentimes, by the time they get to me, it's when their facial nerve has gone out or things like that. And they send it to me thinking, okay, now you can operate on this. And these are very disappointing to operate on, and oftentimes we end up making things a lot worse. The thing that really changed with this disorder, I think, is the rise of the quinolone antibiotics. Prior to the quinolones, the only anti-pseudomonal medications were intravenous, and they were aminoglycosides, and they required hospitalization for months and months at a time. When I wrote my first article with Cy Parisier on necrotizing otitis externa, he would bring to mind his experience at Mount Sinai, where 20 or more patients would be on their service at any one day. all getting therapy for necrotizing otitis externa. And at that time, it carried a 20% mortality. And I haven't had to admit a patient with necrotizing otitis externa for many years in most cases. These patients are treated successfully with oral antibiotics now that we have the quinolones. But it does require a lot of time to treat them. It's also something that is not very well driven by principles of infectious disease, because we typically don't want to give prolonged doses of a specific antibiotic. And so when we talk about giving, 40 days worth of ciprofloxacin, or even, 3 or 4 months of this, our ID partners kind of cringe a little bit and think that we're selecting things. But the nature of the quinolones is that they are concentrated in bone. And so as time goes on, the concentration of the antibiotic increases, and we have a greater effectiveness. It's also one of the reasons why culture is difficult to use to drive this. The culture, the bacteria that you culture at the time that the patient presents and that's in the ear with the granulation tissue may change over time from the effect of your antibiotics, but it may not be the organism that's still causing the necrosis deep inside. So there's still a lot of things about this disorder that are very, very difficult and very, very challenging to treat. And it just takes a lot of time and patience.
So I think there's some really interesting and useful pearls on imaging modalities to help us in box 2. And I really like that medical treatment algorithm that they have in there. You may have to use a magnifying glass to see it properly, but it's a really useful algorithm. Is it still true that once there's cranial nerve involvement, and particularly facial nerve involvement, the mortality rate becomes 50%?
In my experience, it's not been. In my experience, even patients with facial paralysis, I think that if you talk about those that start getting jugular foramen tumors or jugular foramen involvement, I'm a little more scared about that because they get aspiration pneumonia and things like that. But for the patients with facial nerve problems, if we treat it aggressively, usually they will not pass away. It'll take a while for the facial nerve to come back, though.
Yeah, I actually have the same experience in pretty elderly, pretty immunocompromised, maybe on dialysis, etc. If you're just patient and really careful about the oral toilet and the aggressive nature of how much antibiotics they can tolerate, I agree with you. I think patience is definitely a virtue in this particular disease. Esther, do you have a different experience you'd like to share with us?
No, I agree with you guys. I wouldn't say the mortality is at 50% with facial nerve involvement, but I do have to say that by the time I often see these patients, they can have pretty advanced infections, and they do present with the facial paralysis that often, in my experience, it doesn't come back. The function doesn't come back, and it's my experience has been that you lose it, and that's it. I can't think of any patients where their facial function has returned after presenting with the full paralysis or a severe paralysis. And so it's a pretty poor prognosis in terms of the facial nerve recovery, but I wouldn't say it's a high mortality for them if they get appropriate treatment at that time.
I think one of the big problems that we see with this disorder is the idea of when to stop the medications. We were always taught that you get a gallium scan after a certain period of time, and once the gallium or the tagged white cell scan is normal, then you can discontinue. And I use the ESR and the CRP as my indicators of generalized inflammation, and I want to see those be normal before I think about starting them. But I've had many patients that have come to my way that were treated for a year or more for their necrotizing otitis externa on one side and reached all the different criteria, and the treatment was stopped. And 2 more years, it's marching on to the other side. And you can actually see on the MR and the CT scan the necrosis going across. And so do we have a good, reliable way of knowing when to stop our treatment? And I don't know if we do. We just have to be, vigilant about following up these patients. Pain no longer becomes a good symbol, a good symptom to follow. And all these different imaging studies that we've had all have problems with them in terms of being able to localize and know whether there's active inflammation or infection. So it's still a very challenging disease.
Well, thank you both very much. I'm Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. Today, I've had a really amazing time talking about external ear canal disorders with Dr. Matthew Hanson of Downstate Medical Center in Brooklyn, New York, and Dr. Esther Vivas of Emory Medical Center in Atlanta, Georgia. Matt and Esther are the 2 guest editors of the October 2023 issue of Clinics, which is on external ear disease. And you can get this issue and all issues of Clinics either in your personal or institutional library or online at www.oto.theclinics.com. You can access our podcasts at that same site or wherever you get your podcasts. I want to give a special shout out to a new friend and colleague whom I met at the 2023 American Academy of Otolaryngology annual meeting in Nashville, Tennessee, Dr. Gavin Gasson, who practices in the U.S. Virgin Islands. It was really nice meeting him. He said to me that the best book or journal investment he's ever made is his subscription to Otolaryngologic Clinics of North America. And then I asked him, what can I do to make things better? And he very kindly asked me to make my audio sound better. So I have this very fancy setup now, and I'm hoping that it works. So thank you, Gavin. And I hope the audio meets your pleasure at this point. So Esther and Matt, thank you again both for spearheading this comprehensive issue of Clinics and for spending time with me. In our forewords, we all talked about how non-sexy this topic is, but I have to tell you, I have every single copy of Clinics in my clinical office, and this is the only one that's been picked up and read cover to cover by my colleagues who are non-otologists. So maybe earwax is the new black.
Yes, and the last time this subject was done in Clinics was 1996, and I was an author on that version as well.
Excellent. So. Esther was as a child, and I was a newly formed otologist. So.
This is before my fellowship, so it was fresh out of residency.
Yeah, fantastic.
Thank
you again so much. This is really fun.
Thank you all very much.
Thank you for joining us for this edition of the Otolaryngologic Clinics Podcast series. For an exclusive discount on the issue we discussed today, focusing on external ear disease, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms, Clinical Key, and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts.